Thank you for returning. Now, the committee members and I are going to discuss what we have learned today, as well as from yesterday, from our guest presenters, the roundtable discussion, the background materials. As you know, this two-day meeting is part one in our three-meeting series on population-based total cost of care models. After the series, we will submit a report to the Secretary of Health and Human Services. So the report will include our findings from the June and September theme-based discussions as well. But while this topic is fresh in our mind, we want to discuss what we learned yesterday and today about definitions, structural issues, and opportunities related to designing population-based total cost of care models. There's a lot of information to sift through. For our committee members, please check the pocket of the binder for the meeting materials. There is potential topics for our deliberation. And then, of course, we can begin the discussion either raising your hands through WebEx or simply start with your comments. We had this list up yesterday around potential topics, and I think we don't need to keep that list up as we all have a hard copy of the information. And we'll plan to go to approximately 3:45 in our discussion and deliberation. So let me open it up to PTAC members for any initial thoughts or comments on the discussion either from yesterday or today, or on the combination of them. Hey, Larry. Yes. You're on mute, maybe. I don't know. Still on mute. While Larry's getting off mute, Bruce, you have a question or a thought?
So my broad question is kind of related to the fact that Medicare Advantage came up several times, both yesterday and today's discussion. I think Gail Walensky even said that she was a big believer in what Medicare Advantage could be. I don't think she said it quite that way, but she likes the concept but doesn't like the reality of it all, is my interpretation. And so my question is, how would a total cost of care model that was sufficiently well educated, had good sources of data, had good methods, had social determinants of health as one of its objectives, how would that differ from a Medicare Advantage plan that was designed to focus on total cost of care? It seems to me, I wonder if we're going to go in a direction, is that a direction we could consider going in?
Comments from other committee members on this?
Or not.
Yeah, no, I don't know. I was going to sort of not pick on, but sort of ask Lise, given your experience, do you have any thoughts as to whether this is a direction we might want to even consider, or whether that's not really?
Well, a lot of rich conversation and robust models around Medicare Advantage out there. It's really in where some of the most innovative things pushing the edge of what's appropriate as medical benefit and what's effective, especially for social determinants, is being done. So I think the call this morning for less confusion and some standardization around it makes perfect sense. I agree with the consumer perspective of having helped my parents weed through that marketplace, which is very confusing and challenging. But we don't want to lose view or grip of it's that very mission to provide all Medicare benefits plus additional things, often at no cost to the beneficiary, that is creating the innovation. So I'm not sure what the parsimonious choice in the middle of all that is, but it was points well made this morning.
I think on the provider network side, the salient difference is often access, the ability to access. So Medicare Advantage is typically can be a narrower network, particularly in when the provider takes on, or when the payer takes on risk, versus Medicare. So I think that in the way the attribution works, so that's a salient difference that we would have to solve for. And then the other difference would be, I believe, regulatory. Medicare Advantage functions with the ability to have some waivers in place or other things that allow for it to integrate care. And maybe that is a model that we look at and say, are some of those components something that should translate to larger Medicare? And, the question I asked about goalposts, I think that maybe those are things we think about as goalposts in order to lead, sort of lead the country to that sort of goal in 2030.
Mm-hmm. Thank you, Jenny. It's helpful. Larry, you're still on mute. You're still on mute.
I'm still on mute.
No, now you're off. Now you're off.
I'm off. I'm plugging into my phone. It's got to be right.
All right.
So I really enjoyed the 2 days. I learned a lot. And what I have takeaways in my mind from what I heard specifically today was that total cost of care can be defined, probably should be defined, that episode-based models should not just be eliminated, but should be figured out to have them nesting inside larger models. And then the third thing that I think is important, it came out yesterday in our discussion around high beta when we were talking about my high beta concept, and it came out again today, is I'm struck with our future as designing episode models around patients rather than around types of providers. And that's challenging, but it would, if we could succeed in doing that, we would bridge that gap between primary care and specialty care and designate responsibilities accordingly. It's a big task, and maybe it's aspirational more than reality, but those were my three takeaways.
Thanks, Larry. Very helpful. Other thoughts from committee members on what you've heard over the last 2 days or anything specifically today?
I think the other thing to add to what Larry said that seemed to really stand out is that yesterday and today, to limit the subset of APMs and to harmonize them seems to be a very common theme in that sort of movement to total cost of care.
Yeah, I agree. And then bringing in the beneficiary perspective, the thought, the challenge around them understanding if they move into a model, what that model is. Again, not even talking about Medicare Advantage and all the plans there, but just thinking through the advantage of having a smaller number of larger models, thinking of the education piece, because we know certainly the challenge around engaging the beneficiary understanding around whether they're in any kind of model on the fee-for-service side, whether it's a bundle or a larger population-based model. Other comments? Walter, did you hear anything on physician incentives that was interesting to you or thought-provoking?
Um, Not so much on that, Paul, but what did strike me from today's presentation, especially Christina Severance from C3, and this actually kind of gets to Bruce's question about Medicare Advantage. I think one kind of key tool that Medicare Advantage plan providers have access to is real-time, robust data. You should show that slide of all the data sources integrating into a data warehouse, the claims data, the IDT data, the labs data. And it just struck me how important that was to help these new payment models succeed, and I think it's almost kind of sine qua non. I mean, that without which it's really hard to improve care, at least in a timely way. And this was also our experience when we were involved with Model 3 BPCI, part of the BPCI Classic program. It was kind of really hard to improve care when you're getting your data 9 months later, and you have multiple true-ups before you get your final data. So anyways, I just, that was really striking, just how important data is, and kind of, I'm not sure how we solve that problem, but just wanted to raise that point.
Yeah, thanks, Walter. So it was interesting discussion. I know we've referenced carve-out several times in our thoughts around total cost of care, and I think several of the speakers raised the concern around how to use carve-outs and how unintended consequences in terms of how providers or others may determine what's in and out of a carve-out. And so, again, I think this gets back to this whole, one of the questions around engaging, having payment models inside a total cost of care model and how that would work.
Yeah, you remember Mike Cherno's example of waste as an asset, and that was one of his points. Is how do you allocate the elimination of the waste? And if you have a carve out, they're going to try to take credit for as much of that as they can and take it away from the basic plan. I liked also, though, the notion that with a right platform, and if it's big enough, that a lot of these decisions can be made organically, that the decision of whether to have a nested model or some other way of accommodating a certain patient subpopulation can be made within the entity as opposed to imposed on the entity. At least at the conceptual level, I very much like that approach much better. But I'm interested in what others have to say.
Bruce, I agree with you. I found a number of things interesting over these last 2 days. But one thing that kept bubbling up for me was this idea of essential versus ideal elements that would need to be in future state of either programmatic development or consolidation in the marketplace. What I heard around essential elements are, one, access to data, as was previous, access to data, which Walter previously described. In addition, I heard often around this idea of a non-fair playing field, with programs being voluntary to participate as opposed to involuntary, and incentives that keep high performers in the game, and that any program to be successful needs those elements.
That's great, Jen. Thank you. Other Other comments on what you heard over the last few days or themes you'd like to bring out?
You hear me?
Yes.
Couple of great terms that I wrote down when I heard them. Pharmaceutical stewardship. You know, there may be a way of compensating a provider group for pharmaceutical stewardship. I thought that was an interesting thought. I also thought that I think Emily Maxton I was very impressed with, and she said most specialists are participating in care but not driving it, and there's probably a lot of truth to that. And then what still permeates everything was what we heard from Liz Fowler in the beginning. Can we bring something together with CMMI, MedPAC, and PTAC? How do we define transformational care, and how do we define success? Just things to remember. Some very good concepts, though. I love that pharmaceutical stewardship.
One of the things that I thought was interesting was the first speaker today, Sherry, who spoke about fee for service, and just thought about things in a way that I hadn't thought about before. It's a 4-letter word, and so the way she articulated that, and I think that one of the things that we can potentially think about as a committee as well is, there's total cost of care, and obviously we all want to drive there, define it, social determinants of health, equity. All these things need to be worked on, but also what are things that could be accretive to fee for service that lend itself to building a infrastructure for total cost of care. Like someone today mentioned increasing care coordination codes and decreasing just the one-off sort of fee for service codes, because I think that would incent provider and organizations to sort of build that care team.
Yeah, Ginny, I agree. I was struck. She did articulate that whole fee for service quite well, actually. I think we all sort of knew those are, that we often say, oh, we need to move from fee for service to value-based. But given what's going, sort of not promoting fee for service, but understanding some of the sort of strengths of fee for service as it relates to simplification and et cetera.
But she left, I'm sorry, go ahead.
Yeah, go ahead.
She left out something very important, which is the other countries manage the level of fees much better than we do. And we have this paradoxical situation where the providers in those other countries that use fee for service would love to have Medicare's fees.
Yeah.
And yet, within the context of the U.S., Medicare is seen as a stingy payer. And so there's a lot of things that are different between those other systems than ours that result in our spending much more per capita than they do, and that includes the Medicare population.
Yeah, no, I agree. I just, but to Chinny's point, are there sort of strategies within fee for service that help to build this infrastructure that, as for organizations or practices as they prepare to move towards more of either total cost of care or other kind of payment model, and recognizing Larry's comment, which is an important one about any burden to the beneficiary on certain fees on care management and others, but it often will at least begin to get the providers in the mindset around activities for coordination of care, which of course is a foundational to move to any kind of alternative payment.
There's nothing wrong with the concept of paying people for what you want them to do, which I think is what she was getting at. But the other side of that coin, and I think she mentioned that too, was, well, maybe you pay less for the things that don't take you in the direction that you want to go. But in our system, it's been very hard to pay less. It's not so difficult to pay more for some things, very difficult to finance the payment of more for some things by paying less for others.
Mm-hmm. Other comments and thoughts? Jay, you have any thoughts on what you heard today?
Actually, kind of almost what I didn't hear today that I thought was rather interesting, and maybe the group can comment on it. For the last 15 years, we've lived in a relatively low inflation environment, and even though people would always point to healthcare being higher inflation than CPI, we're entering a phase of hyperinflation. So in terms of what our ability to pay for in the upcoming years, in models, social determinants of health, I think we need to be cognizant from an outcome perspective of what works and what real value is. And that we just need to be cognizant of that moving forward, because I don't think, the healthcare dollars are going to compete in a different space moving forward to a degree they haven't in the last 10 to 15 years. And I think everybody needs to be cognizant of that. Whatever model we choose or push forward, what is the real economic impact?
Jay, hyperinflation? Yikes.
We're just going to be in an inflationary environment that we haven't seen for a while. We haven't operated in.
Yeah, that's brilliant. And I think that it'll also lend itself to increased payment for providers, not just physicians I'm talking about, but more ancillary medical staff that need to make the system work. Because post-COVID, we've seen that already.
All right. I mean, we've lost, close to 25% of the workforce. I mean, from a nursing shortage standpoint, physician staffing shortage standpoint, just to have the individuals in place to deliver the services is going to be a challenge in a lot of systems.
Yeah.
It's a great point. May go beyond the scope of our committee, but that's an important point, though.
As we have two more, as we have two more sessions, there may be some discussion with it for a panel.
Mm-hmm.
I think the earlier call for having actuarial representation at both the June meeting and September meeting, makes so much sense in light of some of these pressures.
Yeah.
Oh, you just reminded me to request, thank you for saying that. Could we get SB or NARC to provide us with the specific responsibilities that the actuaries have? I know it's set forth in legislation, but it might be expanded upon in regulation or through other methods. I know that they have the certification responsibility, but I don't really know much more than what we talked about today, which was enough, but we could learn more, I think, if we had the right source of information.
Yeah, I'm sure they can provide that to us. Josh, any thoughts? I know you've been listening closely, I'm sure, over the last couple of days.
Yeah, no, I think I echo a lot of what's been said, which is why I've been quiet, not because I don't disagree. And I think one of the things that I mentioned it a few times in our comments even yesterday is, just this thing that I hope all of us are clear-eyed about this idea of coordinating and nesting requires imposing some structure that takes away flexibility. So I kind of triage every comment that I hear about. We need to let people pick which conditions and which patients and how much risk to take on and how to create the network. That is, at some level, there's a tension at least with that and saying we want to lay these track downs around this episode or that thing within a broader model. And at the risk of perpetuating that point, I don't think there's a one size fits all there, but I think as we test models, it's important just to keep that top of mind.
So maybe we're asking the wrong question, or how to engage providers. Getting back to the earlier point, how do we engage patients? Because if you have a model and you engage the patients, then that will drive and allow the flexibility.
I think so, and I think hope this is accurate, but I would imagine if we looked at every ACO in the country, there are differences, right, for the patient populations, for the environment, and I think I took away from today the importance of making sure people know what they're getting, the beneficiaries and individuals, and yet that variation, if we want that, that's what some of the current state is. Then when we start like appending, an episode model with requirements and specifications, that provides consistency, but there's limitations there too. So no, we all know.
Yeah.
Josh, I think your comments are really important, and it makes me mindful that the stated goal that we heard from CMMI leadership was from the patient lens around participation, 100% participation of patients in value-based arrangements. But what about the provider community? Our models are focused on providers. Is there the same expectation that providers are 100% engaged? They seem to be, to your description, Josh, right? Potentially, from what we've heard, a polarity. It's not possible to have both flexibility and 100% participation of those two entities, much like the comments previously made before that one entity's waste is another entity's opportunity.
That's right. And to maybe still turn back this idea of the essential elements here, I think this is an essential consideration, I would say, because I know we haven't been talking about the last couple of days, but in my work, from my perspective, when we think about models, there are voluntary models, which tends to kind of be related to you can choose to get in and not, and that gets Jen to your point about whether provider has, there's 100% participation. You can mandate participation, right? And you can get 100% participation, creates a whole host of other issues all of us are aware of. And so somewhere in what we're talking about the last couple of days, there is some rough analog to that. How much do we want to impose on the payment models to get providers and patients and beneficiaries engaged? And there's a trade-off somewhere there. So
Great, thank you, Josh.
One thing that we might want to think about in our models, and that was a really good point, Josh, something I haven't thought about personally, is when you do this nesting, and to Josh's point, there's less flexibility, but is that less flexibility because of the attribution methodology? I mean, should we take a step back and say that, maybe there needs to be some revisiting the attribution methodology because it does lend itself to those swings and making it more difficult to induce harmonized models?
I mean, just reacting to that, I would say, one of the comments came up from the earlier part of our session today was this idea of, APMs you have to attribute, right, in some way, and there's some challenges there. And I think it's been well documented when you have beneficiaries who are receiving care under bundle payments and ACOs, that attribution thing who's responsible for the care becomes a challenge. Those are the types of challenges I think will come up if we do nesting or plugging in, models within each other. I'm not saying it's not an issue today, but part of the flexibility that exists in ACOs and other population-based models that exist now is that you don't need to have that, right? That an ACO can decide as the accountable entity, I will spin up this service line, this initiative, and it will involve these specialists and these parts of the clinical team. But it creates less visibility. So the comments from earlier today, I think, were very appropriate to that point. I think kind of a related point, Shani, is that when I think about it, one of the premises of having a nesting of the models, I think it was Valinda who said this. I don't think she's pretty clear about it. She said, I think the way to engage specialists is through an episode-based model. And we can debate that. But if we believe that that's the way to engage specialists, then not having it leaves that uncovered, so to speak, right? If we think there's a better way, that's what I'm hoping the sessions that we do, going forward here through PTAC will address. because that's something to test, to challenge the question, to agree with or not.
Because one of the challenges that we had, we had about 100,000 patients in a Medicare ACO, and quarter upon quarter, I saw, and that I saw almost a quarter of our patients swing. So 25 to 30% of our patients swung in and out of our ACO attribution, because we had other hospital systems that, for example, had cardiologists, and they would gain that plurality and eventually swing out. And so, for engaging specialists and having that sort of structure change could help better engage specialists in that ACO model.
Yeah, I agree. I think that's an ongoing question throughout the June and September. We need to continue to think through. Important question. Do we need these additional models or not? And in what areas? And if we don't need them, then what are the other ways that would work to engage specialists in these total cost of care models?
Yeah, I think looping back to an earlier comment, I think engagement is one thing, communication, and those comments about participating versus driving, right? We've talked about this, but accountability I think is really important. So I think we have an opportunity in the forthcoming meetings to think about, as we hear about delivery models, yes, it's the nuts and bolts of what's happening and who's doing what, but also if we can get underneath that to say who really assumes accountability, who feels that they have accountability over this part of care, I think will be incredibly important. Because you can imagine two worlds, one in which you engage, both in which you engage specialists, but one, you apply that attribution prescriptively. So it's Dr. A or Dr. B or clinician C. And in a world where you don't do that, and I think that just takes us to very different outcomes.
Yeah,
on that point, engaging specialists, I think it was Emily Maxson from Aledade who said that really their focus is on having the primary care provider drive the care as opposed to the specialists. I know in my own clinical practice, I feel like the specialists that I refer my patients to is a reflection of the care that I provide my patients. And so I try to be very thoughtful, especially since I take care of a very frail elderly population where goals of care discussions are really important, and not all specialists are kind of tuned in to that particular aspect of the frail elderly's care. And so, just the thought that, I think Valinda did say subcapitating specialists or having somehow primary care providers be very involved with kind of the specialist spend, I think is an interesting idea.
As an older person, I'm now a consumer of healthcare services more than, and just not an analyst. And I have two primary care providers. One is in general internal medicine, and I get an annual physical and occasionally other services. My other primary care provider is an orthopedist, and he's the person that I'm likely to see more often during the course of the year. So how do you reconcile that? I don't go to my primary care internist to send me to the orthopedist anymore. But when you're in a plan environment, how do you deal with a participant like me who sees a specialist because that's where most of the need arises and doesn't see the primary care doctor all that often?
I don't have an answer to that, I would say. But I think as a general internist and not an orthopedist, I don't have an answer to that. But I do think it raises this another point I want to highlight just for the discussion, which is that when we talk about beneficiaries or individuals receiving care under some form of accountability, that is neither at odds nor completely consistent with everything in their care being under that, right? So imagine if, to use Bruce's example, one of his two clinicians was in a payment model, assumed accountability, but the other didn't. I mean, his care is under accountability, some of it, not all of it. does it need to be, and how would you kind of connect those proverbial pipes? And so I think we could be in that situation, because I don't know that it's just orthopedists. I think we've heard from multiple people, nephrology, oncology. I mean, there are multiple specialties where that might be the case. But if 4 out of my 5 clinicians are within a payment model, or 2 out of 5, is that good? Is that sufficient? I just think that's an issue worth pointing out also.
Josh, I know some ACOs, I'm not sure about Aledade, but some ACOs have kind of taken a page from the MA playbook and establish networks of specialists, right, within their ACO to refer to address that problem.
But even with that, I think doesn't the data suggest that for most ACOs, maybe 50% of the care is outside their ACO or something? I mean, it's a large percentage of the care, it's not actually within, the providers in their ACO.
Yeah. Well, I think a lot of the conversation.
Go ahead, Larry. I'm sorry. Well, one of the issues that arises there is hospital-based ACO employs its certain sets of specialists. Patient really doesn't have choice in who they're going to be able to go to. And, if you talk to a lot of commercial health plans, they'll tell you that this is an issue that they have a difficult time dealing with in some of their ACO population.
Yeah. I was going to make a similar comment, which is just the challenge of network, or to think of it another way, the challenge of geography in linking your specialists into any value-based paradigm, which is potentially in some very large urban centers where you have more specialists than you need. It's easy to use the power of the primary care doctor's referring pen to a high quality, lower cost specialist network that's very thoughtful and approaches care the right way. But in the vast majority of geographies, that is not true, and you simply have to play with the specialists you have access to. So that gives rise to this idea of essentially there's individual sections of this total cost of care concept which are separately standardized and separately valued. And in working in a given geography, there may be some subtotal cost of care model, which is the best you can do given the parameters you have, and how that's valued and operated. Of course, the devil's in the details.
That's probably why you got 50% of the care being provided outside of the network.
Yeah.
And particularly in areas where there isn't a wide uptake of APM models, it's in those areas, typically there aren't any specialists you can refer to that would be willing to take that on. So it becomes that much harder.
Yeah. Now Aledade and similar models have been successful because in the less urban, more rural, large tracts of the country, they're working with the only specialists they have, but then they have the power of relationship with those specialists, and they are, a large part of that specialist's incoming patient stream, and there's a relationship to maintain. But that's a harder tool to wield, frankly.
Well, and then it brings to light, should incentives follow the virtualization of that or digitalization of that? For example, if you're looking at, companies like Rubicon that have digitalized, over 250 specialties, right now the reimbursement for telehealth, has a mandatory in-person care requirement. And so that takes that geography and makes it sort of a stranglehold. Maybe we take that off. Those are things to look at.
Other thoughts about today or yesterday, or?
I just had one final, kind of appended to Lee's comment, which I think is that, there are all these forces, right? That implicitly, if a subspecialty group signs up to be a part of an ACO, they've declared in that participation that they're signaling some interest or a willingness to take accountability or to partner in that care. The other way for groups like that to signal it would be to sign up, right, formally as a participant in a payment model like BPCI, for example. And I think going back to that prior point, like when you think about geography and the supply of clinicians and groups and kind of factor in like the natural way this can happen, and Lee articulated some of those, right? If you have market share, if you have existing relationships, they're the one way around that. I'm not saying it's desirable, but it may come up in the next few meetings is, again, mandating participation for some total or subtotal part, I mean, you can apply a very strong policy there. And again, there's a host of issues that come up there, but short of that, I think you're not going to get away from those unique market and geographical factors that Lee gave us insight into. And so that in some ways is at odds with getting scale, either at the provider or the beneficiary level.
Yeah, we know, right, at the end of the day that unpredictability increases risk. Increased risk has already been a barrier to participation or an intolerance to participate. So if that's not mitigated, it's hard to imagine how this 100% goal will be achieved.
That's great. We only have just a couple minutes. I just want to be sure. Any final thoughts from any of the committee members on?
Paul, one quick kind of aha moment for me from these 2 days was actually just from our last panelist discussion. You know, we've really focused on kind of defining total cost of care with this meeting. And I just thought the whole idea of standardizing definitions around components of total cost of care while leaving some flexibility for each organization to choose those components and kind of have different definitions of total cost of care to remain flexible. It was really interesting, you know, and that's not something I thought of before.
Yeah, I agree. I found that very interesting as well, Walter. And I hadn't thought of it in that way, but maybe a way forward in terms of having flexibility and not strict definition of total cost of care that has to apply, you know, across, but have enough structure so that people understand what the definition is for that particular group.
Yeah, I agree too, and I think it's maybe an avenue for us to provide some concrete information in our eventual report to the secretary that makes a real contribution to the goal eventually.
Yeah. Any other final thoughts? All right. So I want to thank everyone for participating today. Our guest presenters, panelists, members of the public, and of course, my PTAC colleagues. We explored many different facets of population-based total cost of care models. Again, a special thanks to my colleagues on PTAC. A lot of information packed into the 2 days. Appreciate everyone's active participation and thoughtful comments. We will continue to gather information on our theme through a request for input. We're posting it on the ASPE PTAC website and sending it out through the PTAC listserv. You can offer your input on questions by April 15th. Now that we have a better handle on defining the relevant concepts and understanding the broad issues, the next step is studying implementation. So our June public meeting will focus on the best practices for care delivery, improving quality, and measuring the success of population-based total cost of care models. I certainly hope that everyone will join us then. So before we adjourn, I want to express my deep appreciation to the entire ASPE team and the NORC staff for all of their work in making these past 2 days of meetings so successful. So with that, the meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.